Okay, this is the paper I was talking about. And as you can see, it is stated that those grafts showing a low flow, low mean graft flow, resulted as occluded at a mean follow-up of 6 months. And those grafts with a mean graft flow over 70 milliliter per minute measured by electromagnetic flow meter resulted to be patent at the same follow-up. And surprisingly, the higher risk of occlusion was for those grafts onto the small coronary vessels. So I mean that the grafts put on less than 2 millimeter coronary vessel had showed the higher probability to be occluded at the follow-up of 6 months after the operation. But as you can read, it took 38 years to incorporate any procedure, some procedure of intraoperative graft verification into a guidelines for coronary artery bypass surgery. It's surprising, but it's our fault, of we surgeons. So in the last guidelines published in 2010, it is stated that graft flow measurement related to graft type, graft vessel, size of vessel, degree of stenosis, quality of anastomosis, and outflow area is useful at the end of surgery. And the published some cutoff values of two main parameters, the mean graft flow and the pulsatility index. And these parameters, these cutoff are taken from a paper published by Teresa Chiesa, who is in the room, a very outstanding paper, that stated that the mean graft flow should be over 20 milliliter per minute and the pulsatility index should be lower than 5 milliliter per minute, lower than 5, to assess the good patency of the graft intraoperatively. And it is so important, this evidence, that the recommendation of flow graft evaluation in the operating theater is put on a class 1 and level of evidence C, in spite of several papers published in the literature. There are many more than 100, starting from the beginning of the experience with transit time flow measurement. Oh, sorry. It is written in a strange way. Okay. So, what is able to tell us the transit time flow measurement? It is able to give us an analysis of flow trace. It is important to state a cutoff of flow parameters. It is able to predict the patient outcome. And it is useful to evaluate the diagnostic accuracy of the method. So it is one example. This is an historical example from D'Ancona experience from the group of Jacob Berglas. If you, at the end of the anastomosis, you record this kind of flow trace, it's likely that the anastomosis is occluded. So it is mandatory that you should redo the graft. And if you redo the graft, you will probably have this kind of flow trace that is a good functioning anastomosis. And these are parameters of the cutoff parameters of the main parameters of transit time flow measurement. We published in 2006 that cutoff values, in our experience, were 50 milliliter per minute for the mean graft flow and 3 for the PI. But there's a wide range of opinion about this, because many other papers published on this topic, and they found different level of cutoff values, ranging from 3 to 5. And if you have a look of this small table, there is a paper published by Tokuda in which there's even a difference between the left territory and the right territory. It is important to notice that 2 of those 3 papers report an ROC analysis. It is an analysis that is able to state the good accuracy of the method. And a 5 OPI for the left territory from the paper of Tokuda is just at the border of significance for the EAUC, for the area under curve. and the ability to predict the patient outcome. There are two main papers in literature. One of these is published by a Turkish colleague, Nasip Besit, who divided two groups of patients. One group submitted to intraoperative graft measurement and the other one not submitted to this. And he was able to visualize, to show that there's a big difference in overall morbidity, a significant difference in overall morbidity. There's a significant difference in the use of counterpulsation. There is a significant difference in the evidence of perioperative infarction, myocardial infarction, and above all, a striking difference in mortality, in overall mortality. On the other hand, there's a paper by Teresa Kieser in which it is stated that if you find a PI beyond 5, and you don't revise dose anastomosis, you have a big chance to have a patient dead at 6 months follow-up. But it is to be stressed that from this analysis, there are 32 patients excluded for emergency situations. And this is interesting because we should take into account even the emergency situations. And this is the analysis about the diagnostic accuracy. Using the ROC curves, it is in our paper, we were able to find a good matching between sensitivity and specificity concerning those cutoff values of the mean graft flow, the PI, and the percentage of backward flow. But altogether, taking into account all the parameters, all the experiences, we found that this method, the transit time flow measurement alone, accounts for a good negative predictive value, but not for a positive predictive value. I mean that the specificity of the method is lacking. So achieving a diagnostic accuracy altogether ranging by 30 to 80%. And this could be considered just not too much. Looking at literature, the use of epicardial ultrasound is very old because it belongs to the 60s, where it was used to validate some intraoperative specimens using the angiography, the coronary angiography. And the surface echo was used to validate a recent method to analyze coronary angiography, digitalized coronary angiography. So it is something not new, definitely not new. And this is a new equipment because it's true that it is a new method, but it's always true that there's one only equipment that integrates the flow measurements and the chance to take high-resolution epicardial imaging. And this is the VeriQC. We started to use VeriQC in late 2009, and altogether we report the analysis onto a group of patients of 300, more than 300, 333. You can look in the slide the preoperative characteristics of the patients, but more interesting is the number of grafts checked with this method, and we checked more than 700 grafts. They were made 1/3 off pump and 2/3 on pump, and the mean graft flow, the median of graft flow was 25 milliliters per minute, and the median of pulsatility index of our group was 1.6. We went to reclassify those transit time flow specimens using the high-resolution epicardial imaging. So we considered the so-called likely failing graft at transit time flow measurement. I mean, those grafts showing a mean graft flow below 15 milliliters per minute and a PI above 3. And we found 39 grafts out of 717 grafts altogether, so equal to 5.4%. And on the other hand, on the false negative side, we consider likely functioning at ETFM 778 grafts out of 678 out of 717, equal to 94.5%. We reclassified all the grafts, and talking about the specificity, we found that true positive grafts, just 2 out of 717. I mean, those grafts should have been redone, equal to 0.3% of the total graft. But 2 out of 39, I mean that we avoided to make an undue revision on 37 grafts. On the other hand, on the side of the false negatives, we found that out of 678, we found 675 true negatives. So saving 3 grafts about the true negatives, because in these cases, one side of the anastomosis was occluded, and a flow measurement alone was not able to detect the failure. We analyzed deeply those groups of reclassified grafts, 37 false positive, and then 675 false negative. We did find, again, a striking difference, a significant difference in the mean graft flow and the PI. So detecting that there was a true difference on the 2 subgroup of grafts. But in spite of this significant difference, we did not find any significant difference in the difference between the basal and the peak of troponin I after the operation. So demonstrating that the detection, the reclassification, was really useful on a clinical point of view. So it was not a mistake, it was truth. This is the mortality, but it is not important on the issue we are discussing about. But it is important to analyze the 12-month graft failure. We recorded 8 grafts. We had 8 grafts failing in 6 patients at the mean follow-up of 12 months. All the cases were misunderstanding the high-resolution imaging or an inexperienced operator who were making the prediction of patency of the graft. And 4 out of 6, there was the same surgeon who did the mistake. So we carried on an analysis. We divided the period of our experience into segments. The first one from August 2009 up to July 2010, the second one up to April 2011. And we found that the confidence with the method was increasing in time. As you can see, the percentage of, for example, for this surgeon, the percentage of use of the B mode, that is, in my opinion, the most important aspect of this method, increased from 28 to 72%, and the same for the color flow mapping. The color flow mapping is one of the most attractive sides of the method. You know, you look, the surgeon, an experienced surgeon, looks at the color and is convinced that the anastomosis is okay. It is not properly in this way, but it is important to be accustomed to take confidence, to increase confidence with use of the B mode imaging. And this is the influence of the learning curve on procedural accuracy. The 2 curves on the bottom of this graph are for the all graft controlled by transit time flow meter, and those grafts controlled by transit time flow meter and surface echo out of the last year of our experience. And you can see, even if there's no significant difference between the 2 sets of curves, there's anyhow a trend in the behavior. I mean that compared to TTFM alone, imaging allows to increase freedom from technical failures proportionally related to surgeon confidence with the method. So at the bottom line, the use of transit time flow measurement and the echo, the high resolution imaging, is able to lead the diagnostic accuracy very close to 100%, very close to 1. So what's the take-home message? I would draw that in the era of legal disputes, transit time flow measurement incorporation into myocardial revascularization guidelines sounds like an alarm. This issue represents a good reason to make any efforts to increase the accuracy of intraoperative graft assessments, not only for the patient's interest, but to certify our job. Function, transit time flow measurements, and morphology, high resolution echography imaging are important to assess intraoperative graft patency, and by echo, by imaging, and to predict the graft and patient outcome. That is a good issue for the transit time flow measurement. But the key point is to consider this process as a procedure more than a method. So my suggestion is to perform all the methods. Thank you very much.